Greetings and welcome to this video on third generation cephalosporin. In this video, we'll discuss about ceftriaxone and ceftazidime in detail. This is a must-watch video to know about the most commonly used antibiotics like ceftriaxone. If you are new to this channel, do like and subscribe. This is Medicine Beyond Harrison's. Let's get started. So cephalosporins, these third generation includes the ceftriaxone and ceftazidime. These are broad community-acquired coverage. It has a very broad activity against gram-negative as well as few of the gram-positive also. It is the backbone of inpatient empirical therapy. Important difference between these agents are often misunderstood, and now in this video we'll discuss it about it completely. So mechanism of action, basically it's a beta-lactam antibiotic group binds to penicillin binding protein and inhibits the cell wall synthesis. It is a time-dependent killing. Time more than the minimum inhibitory concentration is the more of its killing. So it is bactericidal. So dose and dosing interval are critical, especially in critical illnesses that we will discuss in the upcoming slides. So initially we'll discuss about ceftriaxone. The most important workhorse antibiotic drug that a physician needs to know is ceftriaxone. It's a very old antibiotic, but still relevant today in this modern era of antibiotics. So we'll discuss about this. So contraindication, only few contraindications are there when it is allergic to ceftriaxone and allergic to beta-lactams with this chemically similar R side chains. So penicillin allergy alone is not an absolute contraindication for ceftriaxone therapy. There are a few drug-drug interactions, only a few that you need to know. Lansoprazole, there is additive H-reg channel blockade, so risk of malignant arrhythmias, but does not occur with pantoprazole. So lansoprazole not commonly used nowadays. So you can give pantoprazole along with ceftriaxone. That is not going to be an issue. Calcium solutions cannot be infused with calcium containing solutions, not compatible with ringer lactate. So you must mix it with normal saline and administer ceftriaxone if you are administering as a infusion. So there is risk of precipitation in lungs and kidneys. So always give ceftriaxone with normal saline and not calcium containing solutions. Side effects, main side effect of ceftriaxone that you must know is the biliary sludging. So in a patient with cholelithiasis, avoid ceftriaxone because it can cause cholelithiasis, pseudocholelithiasis due to increased biliary sludging and the ceftriaxone molecule itself forming the sludge. And it can even cause acute cholestasis kind of features, or it can cause sludge pancreatitis. Anything can happen. So avoid using ceftriaxone in these cases. In case of hepatitis and Clostridium difficile infection, try to avoid ceftriaxone. In all these situations, go for piperazolone tazobactam instead of ceftriaxone. So, hematologically, rare complications such as neutropenia, thrombocytopenia, impaired platelet aggregation can happen. Neurotoxicity are quite rare but still can occur. Delirium, seizures, myoclonus, and non-convulsive status epilepticus can occur. So why it is widely used? So it is a very broad community acquired coverage, convenience once daily dosing, 2 gram IV once daily, and good tissue penetration with minimal renal adjustment and performs reasonably well in augmented renal clearance patients also. Well, only the dosing may need to be increased, but still it performs very well with augmented renal clearance and young patients also. So nuances with albumin and augmented renal clearance. So in hypoalbuminemia, when it is less than 2.5 gram, try to avoid ceftriaxone because the half-life decreases, increased renal clearance, there is a risk of underdosing. And if you are giving it, then the 2 gram IV 12 Q12 hourly in case of albumin less than 2.5. Again, for augmented renal clearance, when there is low creatinine or increased renal clearance, may need 2 gram IV 12 hourly dosing. So ceftriaxone in gram positive, it covers Streptococcus pneumonia, resistant strain usually cured except for meningitis, a non-enterococcal streptococci. MSSA, it can cover, but it's not the ideal drug. Cefazolin remains the drug of choice. First generation cephalosporin. If you have not watched that video on first generation cephalosporin, you can find the link to this in this playlist. So staph saprophyticus also there is reduced activity. So it misses Centrococcus completely, Listeria completely, and MRSA completely. So try to avoid using ceftriaxone in these cases. So it has a good coverage again gram positive, except it avoids misses Pseudomonas, ESBL organisms, and AMC beta-lactamases. That is the space organisms. If you are new to this channel, do check out the infectious disease playlist. In the first fourth of this video, we have discussed in detail about the AMC mechanism of resistance. So it has a very good coverage. E. coli, Klebsiella pneumonia, Proteus millabilis, and H. influenza. Respiratory for community acquired pneumonia, it remains the drug of choice. For CNS community acquired meningitis, again it misses listeria and high level resistant strains for streptococcus pneumonia, but still remains the empirical antibiotic of choice. For abdominal and genitourinary infection, for UTI, for pyelonephritis, for spontaneous bacterial peritonitis, everything, ceftriaxone remains the drug of choice. In case of bacteremia, endocarditis in select cases, and Lyme's disease, also ceftriaxone remains the drug of choice. Standard dosing is 1 to 2 gram IV once daily for most infections. The standardly followed dosing is 2 gram IV once daily. The when to use 2 gram IV 24 once daily, that is severe infections, for bacteremia, endocarditis, obesity, critical illness with the ARC and hypoalbuminemia, risk of resistant organisms, suspected or known MSSA, and Lyme's disease also. So many experts favor 2 gram per day dosing as default in ICU setup also. So only indication where you give 2 gram IV BD or twice give 12 early is meningitis, CNS infection. It has a synergistic therapy with endocarditis, severe ARC and high MIC pathogens also. You can go with 2 gram IV 12 early. So special population, renal failure, no renal adjustment required because of primary hepatic elimination. So avoid in hepatitis patients. In case of augmented renal clearance, if MIC is more than 0.5, any 2 gram IV cure 12 early. In case of obesity, at least 2 gram per day is required. ECMO standard dosing is usually adequate. Pharmacology, it's a moderately weight molecule such as 62 gram per mole. It has a high protein bonding and has a half-life of 7 hours. So IV route or IM route can be given. So it is the time above the minimum inhibitory concentration. Because of its long half-life and high protein bonding, you can infuse it once daily and it remains in the blood throughout. So that once daily dosing is sufficient for ceftriaxone. So 50% renal, 50% biliary excretion, excellent urine and bile penetration, so good at CNS at high doses also. So now we have completely discussed about the ceftriaxone and its clinical use cases. Ceftriaxone even remains the drug of choice for nalidixic acid resistant strains of enteric fever, that is salmonella typhi also. For MDR typhoid also, ceftriaxone remains the drug of choice. When ceftriaxone is resistant, then you can go for azithromycin. So in case of now we'll go into ceftazidime, the main anti-pseudomonal third generation cephalosporin is ceftazidime. Predominantly nowadays it's used in combination with ceftazidime, avibactam and aztreonam combination, whereas in that case avibactam and aztreonam remains the main molecule of choice, main active molecule, and ceftazidime just remains as a synergistic action. So currently ceftazidime is very minimally used alone as a drug. So contraindications are mainly ceftazidime allergic and aztreonam allergy, high cross-reactivity due to side chains, and pre-existing seizures or delirium. Try to avoid ceftazidime. Interactions, there is very minimal drug and drug interactions. So neurotoxicity is a very major adverse effect of ceftazidime. So in case of CNS infections or patient with seizure disorders, in case of already patient having delirium with myoclonus, try to avoid ceftazidime. In other rares, transaminitis can cause drug fever, hematological manifestations such as hemolytic anemia, neutropenia, and Coombs positivity, and interstitial nephritis also in few cases. Spectrum is very poor gram positive coverage compared to ceftriaxone, although they remain the third generation cephalosporin. Very poor gram negative, it can cover all the Enterobacteriaceae and the Pseudomonas aeruginosa also. That is the added advantage of ceftazidime when compared to ceftriaxone. So if you suspect Pseudomonas infection, then you can go for ceftazidime. Again, should be avoided with inducible IMC organisms, that is the spice organisms that we have discussed in previous modules. Cefepime is usually superior over ceftazidime because Cefepime is a fourth generation cephalosporin has better activity as a SAMC producer. Cefepime has better gram-positive coverage and a safer empiric choice. Similar neurotoxicity risk when compared to ceftazidime. So ceftazidime strongly selects for MDR versus MRSA, MDR pseudomonas and ESBL organisms. So some hospitals have removed ceftazidime entirely these days. So ceftazidime as a molecule alone is not currently being given in most of the hospitals. Ceftazidime, when it is used, very limited role. When you suspect Pseudomonas and Cefepime is unavailable or there are no better alternatives exist, you can go for ceftazidime because Cefepime also covers against Pseudomonas. Standard dosing is again 2 gram IV, 8th hourly. In case of severe infection, meningitis, and obesity, go for 2 gram IV Q8 hourly. When GFR is less than 50, 1 to 2 gram Q12 hourly. And the GFR is 10 to 30, you can go for 0.5 to 1 gram Q12 hourly. In case of less than 10 GFR, it's 0.5 to 1 gram Q24 hourly. In case of ECMO, pharmacokinetics unaffected, you can go for regular dosing also. So it's again a similar molecular weight molecule, 636 gram per mole. Protein binding is very low, that is 10%. So that makes it needs a multiple dosing per day. Half-life is 2 hours, very short half-life, and excellent CNS and urine penetration. It is almost excreted 85% unchanged in the urine. In case of renal failure, half-life extends to around 14 to 30 hours, increasing its toxicity also. The zone is ceftazidime. Mainly, it covers against Pseudomonas ceftazidime. We have better gram-positive coverage for zone, and CNS infections can cover by ceftazidime. It's commonly ceftriaxone is used. Once daily dosing is there for ceftriaxone, which is a major advantage, and resistance selection is very high in ceftazidime. To try to avoid that. Empiric use for ceftriaxone is there, not for ceftazidime. Only in case of suspected Pseudomonas when Cefepime is not available, only for ceftazidime. So common clinical mistakes are using ceftriaxone for Pseudomonas and using ceftazidime as empiric and ICU therapy because it misses the major gram-positivity organisms. Underdosing of ceftriaxone in hypoalbuminemia, missing AMC risk organisms, is spice organisms, ignoring neurotoxicity in renal failure patients in treatment with ceftazidime. All these are major blunders that you must need to remember. You should avoid all these things being a physician. So together we'll create better physicians among ourselves. So final take home message, ceftriaxone is a community acquired workhorse. It's the dose as adjusted in critical illnesses. Usual dose is 2 gram IV once daily. In appropriate scenarios that we have discussed previously, you can go for 2 gram IV 12 hourly. So ceftazidime nowadays a very narrow role only for pseudomonas coverage. It's nowadays largely replaced by cefepime. So correct dosing is equal to efficacy plus safety. So always give ceftriaxone is 2 gram IV, 24-hour dosing. That's the final take home message. So if you like this video and watch till this end, do that like and subscribe and share it with your friends. In yet another video on this antibiotic series, we'll discuss more. Thank you for watching.